Our next presentation is Lynette Cooper. She's a wife, mother, nurse practitioner, and nursing educator who spent the entirety of her career caring for women and children. She's most passionate about the health disparities that Black women face when seeking health and obstetric care. She has devoted her career to educating nursing students and healthcare providers about the implicit biases and the medical racism that contribute to the poor outcomes experienced by this population. We won't have a live Q&A after this presentation, but all questions will be answered by email, as with some of our earlier presentations.
Hello, my name is Lynette Cooper. I will be presenting today on systemic racism as a barrier to sexual health. I am a clinical assistant professor at the University of Iowa in the College of Nursing. A little bit about me. Oops, let's go back. I have no disclosures. I've listed my education and research interests and clinical background there. Time is ticking on this presentation, so I won't spend a lot of time on that. But of note, as an RN, I worked primarily in NICU and mom, baby, and women's health. And as a nurse practitioner, I have spent quite a bit of time in urgent and quick care settings, lots of COVID work this last year, but also in developmental and behavioral pediatrics, as well as a community practice as the nurse practitioner for a young parent program, caring for moms and babies, families and their children, but lots of mommies and babies. My research and other interests include health disparities, health equity, implicit bias, and I am a founding member of the Black Women's Maternal Health Collective here in Eastern Iowa. I'm going to jump right into the presentation. I will be discussing maternal health care on a global scale, and I'll be discussing how the U.S. fares on these measures. Again, this is a sexual health as a larger umbrella. Those themes will be brought in, but I am going to focus a lot on maternal care, health care, and maternal mortality. I'm going to discuss maternal health care as a human right. I'm going to discuss health inequities within the context of history, and I'm going to discuss addressing implicit biases as a first step in improving maternal care for Black women. So, maternity care and safe maternity care is a global priority. The global consensus recognizes that many poor maternal health outcomes are not inevitable, but are instead the result of laws, policies, and institutional practices that can be changed. Studies have concluded that probably about 60% of maternal death in the U.S. is preventable. And the U.S. also recognizes that maternal health rights are a fundamental human right and has made a commitment to respect, protect, and fulfill this set of human rights. However, going the wrong way. There we go. Poor maternal health conditions in the U.S. have come under international scrutiny. So the global community is noticing that we say we have a commitment in the U.S., but our outcomes and our practices are not necessarily consistent with that. And what they've noticed and identified as particularly concerning is our lack of access to quality, affordable care, structural and institutional racial discrimination, and the persistently high rates of maternal mortality. We tend to have some pretty high rates across the board, but especially for Black American women and also Indigenous women, which we will talk about a bit too. So this first graph, this is just from 1987 to 2015, and you can just see that upward trend. And we're still kind of, there's dips and hills and valleys and things over the last few years, but we're still trending upward for the most part. And then the other chart there shows on the right developed nations. And the U.S. is there at the top, and this is pretty much over the last since 1990 from 2013, but you can see our rates increasing while the rest of the country's rates have been consistently decreasing. So we've got a problem in the U.S. And this has some racial connotations. So this first graph, map, shows what it looks like from state to state, what maternal mortality looks like from state to state. Essentially, the lighter the color, the lower the maternal mortality ratio, the darker the color, the higher. So, for example, if we look at California from 2005 to 2014, we see 8.3 maternal deaths per 100,000 live births. Okay, that is for the general population. But in the map below, you can see the rates for non-Hispanic Black women. So while it's 8.3 for the total population for Black women in California, that number increases to 28.6. Now, I also want to point out, don't be fooled by the light colored states. That just means that the majority of them did not have enough data. I'm guessing maybe there's not enough Black people in those states, or we just don't have the data. But what's important about these maps that I really want to point out is that even in states that are doing relatively well, so California, Nevada, some of the states on the East Coast like Maine, if you're Black and in those states, your rates will still be consistently about 3 times higher, your mortality rate. So even in states that do maternity care relatively well, that does not necessarily mean that Black women are going to do well in that state. Although even when it comes to Black women's maternal mortality across states, some states are noticeably worse, okay? So whenever I talk about this topic, or really any health equity topic, especially when we are dealing with race, I like to bring in this book, this Medical Apartheid book. If you are a healthcare provider, or if you are a layperson that just wants to understand more about this topic, you need this book. This gives, most of us know about Tuskegee, but this book gives a detailed and I wouldn't say, I will say comprehensive look at the history of the relationship between Black Americans and the medical and research community, which has largely played out pretty negatively. And so take a look at this book when you get a chance. There's one quote that I like to bring out, and it's, "The much bewailed racial health gap is not a gap, but a chasm, wider and deeper than a mass grave." And that sounds pretty bleak, but when you understand the history, then that's where we are. Okay, and nowhere is that gap more evident than in maternity care and outcomes. So this other graphic that I have at the bottom here, that tiny circle represents heart disease. So a Black woman is about 22% more likely to die from heart disease than her white counterpart. The middle circle, the 71%, that's cervical cancer. So she's like 71% more likely to die from cervical cancer than her white counterpart. But that big circle, 243% more likely to die from pregnancy or childbirth related causes. Black women are 243% more likely. And that depends on where you are. That's just a national average, which we will talk about. So in general, Black women are, with the latest statistics, are about 3 to 4 times more likely to experience a maternal death in the U.S. than white women. That rate varies. So for example, in Iowa, Black women here are 6 times more likely to experience a maternal death than their white counterparts in Iowa, in this state. Now, those rates again vary regionally. So in a place like, say, New York City and Washington, D.C., with large African American populations, you can see rates up to 12 times. However, in other places like the southern U.S., you can also see rates of up to 12 times. So my point is that this is a problem. Urban, rural, sea to shining sea, north, south, we have an issue. Black women are dying at epidemic rates from childbirth-related causes. This map here at the bottom, this shows maternal death by race. And what's important to see is that the darker purple is Black women, and kind of the medium blue is white women. But also of note is the lavender, the lighter purple. That is American Indian and Alaska Native, so our indigenous population. And so while Black women are 3 to 4 times more likely to experience maternal death, American Indian and Alaska Native women are about 2 to 3 times more likely. And in Iowa, it's also 6 times the rate of their white counterparts. So this is a real problem. Another thing to point out, just as an aside, is that when Black women are educated, have access to care, and are wealthy, you would think that maybe these gaps would close. However, they do not. So I'll just use myself as an example of educated, not wealthy. But as a Black woman with a doctoral degree, I am still 2.5 times as likely to die or more likely to die from a maternal death than my white counterpart, not that has a doctorate, but that has less than a high school diploma. So my rates of death are still 2.5 times that of a white woman that does not have a high school diploma. And so we've got a problem that even when we have access to care, education, all the things that we think would improve health for a population and improve these rates, that does not necessarily work for Black women in the U.S. So we need to be looking at more. We need to be looking at things like access and all that, absolutely, as a first step, but that is just a first step. So I'm switching gears and we're going to talk a little bit about history. I was talking about where we are. So I want to talk a bit about how we got here. And I am just going to read these words because these are my words. And this is something that I like to say anytime I do a presentation like this. So it is important to understand that health disparities and health inequities, particularly along racial lines, do not exist in a vacuum. Meaning they didn't just happen. It's not just the way it is. There is some history to why it's the way it is. So they are the consequences of history and policies that were enacted with the intention of excluding some from enjoying the full benefits of American life. Without acceptance and understanding of this basic principle, it's easy to shift the blame to individuals and communities that are on the receiving end of disparate treatment and outcomes. So it's easy, if you don't understand that there is a huge historical context, a hundreds-year-long history to this, then you will think something is wrong with Black women. And something they are doing is causing all of these wide disparities, okay? So that's Thomas Jefferson. Here's a quote from President Jefferson. I advance it therefore as a suspicion only, that the Blacks, whether originally a distinct race or made distinct by time and circumstances, are inferior to the whites in the endowments both of body and mind. Now, this is the same person that wrote, all men are created equally, that they are endowed by their creator with certain unalienable rights, that among these are life, liberty, and the pursuit of happiness. So we have this contradiction here. All men are created equal. However, the Blacks are a distinct race and are inferior to the whites in body and mind. He also has lots more thoughts on this issue, but I think that'll suffice. So we've got this contradiction. How do our founding fathers reconcile this contradiction that all men are created equal, but not the blacks? Okay. Well, they had the scientists and the doctors of the day, the medical establishment and research establishment of the day, to bolster that argument that black people are a distinct race, unlike white people. And so one of the ways or practices that supported and proved this was the practice of Negro medicine, which was like, think of it like a subspecialty of care that, of medicine that specialized in caring for the black enslaved population in the South. Okay, so here we have Dr. Samuel Cartwright. I just like to pull him out because he's one of the more notable Negro medicine practitioners. You can actually go read his journal articles and his writings to this day, including Diseases and Peculiarities of the Negro Race. He also is credited with some of the more popular diagnoses of the diseases of enslaved black people. One of them is, I've heard it pronounced drapetomania and drapetomania, so tomato, I'm not sure. Now, this was a widely accepted category of mental illness that supposedly caused enslaved blacks to seek freedom. What's important to understand is what was normal behavior, and this is even beyond slavery. This is well into the 20th century, that what seemed normal for white people was considered disease and or criminality for black people. So wanting to be a free human being was a mental illness. Okay, and he also had a diagnosis, dysesthesia ethiopica. Again, I could be mispronouncing these, but this was just a vague suite of diseases or a vague condition that anything from laziness to mental feebleness, we might call this like a diagnosis of exclusion or something today. But basically, if they were displaying any number of symptoms, they were diagnosed with dysesthesia ethiopica. So anything from laziness or perceived laziness, they work for free, to mental feebleness, to lesions and insensitivity of the skin will be given this diagnosis. And would you know that the cure for this was whipping and hard work in the sunshine? And so they display this condition, they get this diagnosis, you whip them more and you work them harder, okay? Also, this condition was more common among free Negroes. So people that were not, black people that were not enslaved tend to show this more, which was proof that black people needed to be enslaved for their own good. Okay, and all of this I'm saying in quotes, but this was the thinking of the time. This was the mentality, widespread. Okay, so and again, Dr. Cartwright was one of the more notable practitioners. But Negro medicine was widely practiced wherever there were slaves, okay? So some of the tenets, this is the unfortunate thing, some of the tenets of Negro medicine are still very much, some of the themes and echoes are still common in medicine today. So for example, black people don't feel pain in the same way. This idea of black people overreacting about their pain and symptoms or malingering. Those themes are actually still present in healthcare today and contribute to systemic racism and poor outcomes for black people. So this is where I'd have some audience participation if I had an audience. But everything from Negro medicine, eugenics, even some aspects of physical anthropology, we call them scientific or biologic racism now. But what was it called then? I would usually let you guess. But back then, it was just called science, okay? And why did the U.S. and the Western world pretty much the slaveocracy is what my U.S. history teacher used to call all the places that own slaves. Why did they need this scientific racism? Why did they need this corroboration from the medical and scientific community to, to say that Black people were inferior? Well, they had to justify slavery. Otherwise, you are a barbarian. To enslave and treat people, and however bad you thought slavery was, it was worse. Okay? And so you had to be a barbarian yourself. You had to be less than human yourself in order to inflict this kind of torture on other human beings. So you make them not human. Okay? All right, so more Thomas Jefferson here. He says, I consider a woman who brings a child every 2 years as more profitable than the best man on the farm. What she produces is an addition to the capital, while his labors disappear in mere consumption. So now we're starting to talk about the Black body, the Black woman's body in particular. Okay? I have heard it stated that the Black woman's body at this time in history was the economic engine of the U.S. Okay? So the U.S. outlawed the import of enslaved people from Africa in about 1807. Okay? So we had another nearly 60 years of slavery in the U.S. And so if they could not continue to import enslaved people, how did they get more slaves? They bred enslaved women, and yes, bred. Okay? So here we have the Black body, the Black woman's body being controlled in order to increase the wealth of her white enslaver. Okay? So I want to talk about Black women's bodies. This is where we start this conversation of Black women's bodies throughout history. Okay, so I'm going to talk about 3 women in particular. We have Anarcha, a 19th century enslaved Black woman, Fannie Lou Hamer, a 20th century Black woman and civil rights activist, and then we have Serena Williams, who most of us, or all of us, if not all of us, are familiar with today. Okay, in order to even talk about Anarcha, we need to talk about James Marion Sims. If you are in healthcare, especially if you are a physician, you probably know who James Marion Sims. He's credited with lots of advances in gynecology. In fact, we call him the father of modern gynecology. We credit him with the speculum. We credit him with many procedures, including the vesicovaginal fistula repair, which I'll let you look that up. It was a very debilitating and shame-inducing condition that women suffered during this time. It pretty much, in essence, made them a pariah. And so in order to perfect his technique for improving or for repairing this vesicovaginal fistula, and for many other things, he practiced his techniques largely without anesthesia, and even the anesthesia that was available at the time, because there was some available at the time. He practiced on enslaved women, including Anarcha. Okay, and so this is one of the early introductions of Black women to medicine, to women's health. Okay, I'm going to move on from Dr. Sims. I'm going to move to the 20th century here. Now we have Fannie Lou Hamer. Now, Fannie Lou Hamer is we can say lots about Fannie Lou Hamer. She was a civil rights activist. But the one thing I want to bring her into this conversation for is that she coined the term Mississippi appendectomy, or at least she made it famous. And these were forced sterilizations, or sterilizations performed on Black women, poor Black women in the South, from the 1920s through the 1980s. And she herself went in for a procedure and came out with the Mississippi appendectomy. Okay. Also of note is that both Latina women and Native American women, and pretty much anyone who was considered undesirable in the U.S. up up through the 1980s, underwent large numbers of forced sterilization in those populations. So this is not unique, especially for women of color, okay? So again, what is that doing to the relationship between Black women and the medical system, okay? And then we have Serena. I am going to just paraphrase her experience as much as I can here. We know who Serena Williams is. She is in her late 30s. She had her first child a couple of years ago. Before pregnancy, she had a history of, I don't know if she has a clotting disorder. I would have to confirm that. But she had a history of DVTs and pulmonary emboli. And so when she was in labor or immediately postpartum, she had a healthy pregnancy, great pregnancy, but her labor and delivery course and her postpartum course was a bit rough. She ended up having the symptoms of a PE, and because she'd had a pulmonary embolism in the past, she told her nurse, I think I have a pulmonary embolism. I can't breathe. I'm in pain. And basically what happened was they did not believe her. And so her care was delayed until finally they did the necessary tests and discovered that she did in fact have a PE. And there's more to this story, but what's important and what's notable is that she wasn't believed, which is a common theme among healthcare for women in general, but even more so, it's even compounded when that woman is Black. So there's other historical events that I won't get into. We know about Tuskegee. We know about Henrietta Lacks. We also know that hospitals were not even desegregated until 1965 and did it only under threat of missing out on Medicare funding. So my mother could not have been born in every hospital in the U.S. So how does this history, this long and tenuous history, contribute to iatrophobia? First, what's iatrophobia? Iatrophobia is basically, it means fear of the healer. But think about it this way. Think about how that manifests for really any marginalized community, but especially Black people and Black women, how that might manifest today. It's not that Black people are shaking in their boots when they meet a physician, no, but many don't necessarily trust healthcare, okay? And it's a very real lack of trust because of this history. Okay, it's not personal to the provider, but it's how do I know that whatever you're doing is really intended to help me when this institution, and I mean the whole institution of healthcare, has a history of hurting me and people like me. Okay? So let's look towards solutions here. What can the healthcare community do? Okay, we need to commit to equity. Like, we need to understand that all of these things are happening, and we need to acknowledge them, and we need to move toward equity. Okay, we also need to understand the concept and commit to reproductive justice. Much of women's reproductive rights has, over the last, decades, has been focused around abortion rights, which is necessary. But that does not tell the whole story, particularly for women of color. So people need to understand, or providers need to understand, this concept of reproductive justice, okay? This means that people have the right to have children or to not have children, to parent one's children, and to control one's birthing options. That bodily autonomy is something that Black women and women of color have been denied in this country for the entire history of our country and our existence in this country. We also need to understand and acknowledge systemic racism in healthcare. Okay, we need to understand what stereotyping and those kinds of things do to the health of a population and how we deliver health care. We need to understand concepts like weathering and how the stress of being Black American has affected Black women's bodies. And we need to really start looking at implicit bias. And that's where I want to end, okay? Implicit bias, this is what individuals, what you can start to do to work on your interactions and how we can improve care for Black women, okay? Implicit biases, these are attitudes and beliefs and stereotypes that are below our conscious awareness, okay? Meaning we don't necessarily know that we have them, but we all have them. Okay, and they're not just racial, they can also be related to gender or socioeconomic status or gender identity or religion. Okay, but what's important about implicit bias is that it affects and can predict our behavior. So even if you don't know that you think that, that all Black women are sexually promiscuous, when you care for Black women, your bias may show up and may affect her care. So for example, you may ask her, do both your kids have the same dad? Without really intending to be harmful, but that is your bias and the stereotyping that may be below your conscious level at play. I've had that question before. Okay, so why do we need to discuss implicit bias? Okay, it's pervasive. Again, it predicts behavior. Most folks are unaware of their biases, and especially in healthcare, they have real world consequences. You can really hurt and harm and even cost your patients their lives, okay? And evidence shows that we have real discrimination in healthcare and that within healthcare professionals, implicit bias is present just as much as it is in the rest of the population. So we don't like to discuss this because we tend to think, oh, this must mean I'm not a good person. That's just not true. We all have biases. But the important thing to do is to really confront those biases when they arise, challenge others to do the same, try to make connections with people that are different to maybe challenge some of those biases that you may have, and even consider taking the Harvard Implicit Association test, which are not perfect, but it is one tool. So I think that's where I will end, and I also have lots of resources and references, and I think that's it. Thank you.
Thank you, Lynette.